Hi, everybody. Welcome back to this first concurrent session of our NCCRT annual meeting. Thanks again for joining us. We're so happy to be here together virtually this year. So we are getting started with this session, which is innovative strategies to reach patients for colorectal cancer screening during COVID-19. I'm really excited to welcome back, have the pleasure of moderating this session. I'll quickly introduce our speakers, and then we'll dive right in to the presentations and then have plenty of time for discussion. So today we'll have three panelists. Renay Caldwell, the Director of Navigation Services for the Colorectal Cancer Prevention Network. Second, we have Michael Sapienza, the CEO of the Colorectal Cancer Alliance. And then third, Dr. David Greenwald, who's Director of Clinical Gastroenterology and Endoscopy at the Mount Sinai Hospital. So we're really looking forward to this session to build on what we just heard in the first session. The same things apply for putting your questions in the chat function of the CVent platform, and we'll address those during the discussion part of our set time together today. I also want to remind people to go to Slido.com, which is a platform to allow for continued feedback and interaction with your fellow attendees, a chance to discuss what you're hearing, what you're learning, additional questions along with the chat function with the individual presentations. Again, it's Slido.com. If you just put in Slido in your search function of your browser, it will get you there. When you get there to Slido, the code you put in is NCCRT 2020. So with that, I'll do two things. One, remind you for full bios of our esteemed speakers. Remember, those are available on the CVent platform also. And I'll go ahead and turn it over to Renay to get us started.
Thank you, Laura. Today, I will be sharing the innovative strategies the Colorectal Cancer Prevention Network has created to achieve FIT completion in a virtual setting. Next slide. The mission of the CCPN is to reduce colorectal cancer mortality through education, awareness, and the provision of screening services. Our program is a patient navigation-based screening program, and all screening services are coordinated through our locally located navigators in different regions across the state. We provide individual colorectal cancer education, coordination of screening delivery, detailed instructions, and reminder calls for all of our participants. Through this design, the program has achieved exceptional compliance in both open access colonoscopy and FIT compliance in South Carolina. Today's presentation will focus on steps the CCPN has taken to maintain compliance to FIT screening in the world of COVID. Next slide. The open access colonoscopy program began in 2008, and the FIT screening program began in early 2018. The program model was originally delivered as an in-person navigation, which took place at the patient's medical home. The kit provided to participants during navigation for FIT contained the FIT collection kit and instructions. An example of our materials are shown here. The instructions are in 18-point font, contain images to assist with language and reading barriers, have gloves to address sanitary concerns, and a postage-paid envelope for shipping. A tracking label was later added following our virtual model implementation due to delays in delivery and lost mail related to COVID. Next slide. The education provided in our program is delivered by a PowerPoint presentation with images and colorful content to maintain participant engagement. An example of one of our slides is shown here. Information includes colorectal cancer education and information about the type of screening the participant will undergo. Also, information and education is provided on risk factors, know how family history plays a role, and health promotion, including lifestyle changes such as smoking cessation and alcohol consumption. Next slide. At the onset of the pandemic, the CCPN looked into ways that we could modify the program without sacrificing compliance and education. So as an addition to our short segment education videos on our website, a FIT education video was created to provide a memorable and entertaining format to achieve CRC education and FIT instructions that could be accessible to anyone. As part of our new education, the PowerPoint is completed in a virtual classroom environment with the patient navigator and the participant, or by phone when internet access is limited for the participant. The patient navigation includes presentation of the education video, and we also provide a web link, so participants may review as many times as they would like, or when internet access is later available. Let's take a look. We are now going to go ahead and go through the presentation of the outcomes of our data. I'm so sorry you could not see the video or hear it. In our in-person navigation that we have presented for the 2-year period beginning in 2018, we had a 95% return rate. During that time, we all met patients within the in-clinic setting. And since implementing virtual fit in June of this year, we have achieved an 83% return rate. The largest issue that we have seen is not returned, which we identify with those individuals where we have not really had the opportunity to create that one-on-one bond. Our patient navigators are absolutely fantastic with reminders and calls to the patient. We even give tips on how to please leave the kit on the back of the toilet so that there is no uh-oh and they are ready to go. As far as mail delivery, we have noticed a delay in mail delivery with our fit kits in light of COVID with more online shopping these days. These delays have brought concerns of specimen integrity. The program is now monitoring the delivery of the kit, not only to the patient, but as well as to the lab through tracking and looking at delays and to see if integrity is being impacted. As far as the decrease in compliance, it is minimal. And as far as unable to process across the program for the past 2.5 years has been significant. And we really contribute this to the fit education and the great work of our patient navigators. We are very, very happy with the results in our medically underserved population. Next slide. This is our website located at crcfacts.com. We hope you will check out other educational videos located within the pages and on the resource page. We have a clear liquid diet video we use with our open access colonoscopy patients that was developed by our navigation team during the COVID shutdown. Never have colon prep instructions been so much fun. We hope you enjoy our other 8 animated videos. Please feel free to review and share. Thank you so much for today's presentation opportunity.
Thank you so much, Renee. We'll look at figuring out a way to make sure you all have the links for the videos so you can watch those on your time away after this. Sorry for our technical difficulties. It's part of our world, I guess, as we're all navigating this space. But thank you so much for your presentation, Renee. We'll look forward to some discussion later on. And next, I'm going to turn it over to Michael Sapienza, CEO of the Colorectal Cancer Alliance.
Thank you, Laura. I really appreciate it. And thank you, Renee. Great presentation and congratulations on all the important work you're doing in South Carolina. I wish we could have seen the video. I love the animated videos. So, as Laura said, hopefully we'll be able to see that later on. I'm going to be presenting on behalf of the Colorectal Cancer Alliance and actually a coalition of organizers about screening during COVID, a 2-pronged approach, awareness campaign and patient navigation. Next slide. So as you can see here, our campaign goals: save lives and increase screening rates, specifically back to pre-COVID levels in key markets. More importantly, reach the at-risk and underserved communities, deliver messages and resources to providers, mainly primary care physicians, et cetera, and tie into a long-term strategy for patient navigation of the Alliance. And I know many others believes that patient navigation is key. We just heard from Renee about the fit. We've heard from others about colonoscopy, no-show rates, et cetera, and such an important piece around navigation. Next slide. So in March, when this hit, a bunch of us started saying, as I'm sure many of you were thinking, this is going to be catastrophic for colorectal cancer screening rates. And the National Colorectal Cancer Roundtable, the Colorectal Cancer Alliance, and many others got together, and we held our first webinar in May and put out a press release. And then we co-authored a guidance document on screening during COVID, as did a bunch of other folks across the country. And, we said, all right, it's great to put out literature. It's great to put out a white paper, but how do we put this information that we all work so hard together into action? And you can see here on the right side, you look at our tactical approaches. Number one, it's a public awareness campaign to feed the screening funnel, and second, the centralized patient navigation portal to drive screening completion rates. Next slide. So in terms of how we defined our audience, we did look at the 45 to 65 age group, and we're really prioritizing right now the 45 to 54-year-old media buy, knowing that, yes, we still have draft recommendations from the Preventative Task Force for 45 to 49, but those people are going to be getting ready to be screened, and we really think it's important that they know. Obviously, race and ethnicity, white, Black, Hispanic, Latino, segmentation, et cetera. You can see here the unscreened, late screened, average risk, high risk, those experiencing symptoms, and again, Black and brown communities. And I'll just highlight on the right-hand side, we are using LinkedIn specifically around primary care outreach. Next slide. So we're having a multi-channel communications campaign. So as I said, the first piece is around this PSA. So you look at our own channels. So that means, the Colorectal Cancer Alliance's social media, et cetera. And in terms of shared, we have a bunch of partners, Olympus, Exact Sciences, Boston Scientific, a bunch of others. I know I'm missing some, of course, the National Colorectal Cancer Roundtable. And then earned TV, et cetera. Craig Melvin, the Today Show, already did a little piece on this. And then paid. You'll probably, if you live in some of these cities, you'll be seeing us follow you around the internet, just like if you go to buy, a nice pair of shoes or a new jacket, et cetera. You'll start to see these ads showing up to encourage you to get screened. And then also on social media and in digital. Next slide. So here are the actual markets that we are looking at. We did a phase 1 2-week test in 3 particular markets based on screening rates in those markets: Philadelphia, Washington, D.C., and Houston. And now we have actually waited till after the election. And last Monday, we started in the first 5 cities: Philadelphia, Washington, D.C., Houston, Atlanta, and Phoenix. We are looking to expand this specifically to the following cities, and not in any of that particular order. They're not really listed in order, but obviously a lot of unscreened populations in those areas. And I want to be really specific. So if we're talking about Washington, D.C., it's not just the city proper, but we're talking about the entire, what we call the D.C. metro area, or in Philadelphia, the entire kind of tri-state region. So not specifically if we're in LA or Chicago, just the city proper, but all across those regions. Next slide, please. So you can see the key messages here. This is probably nothing new to all of you, but really important. Colorectal cancer screening can save your life. All screening options are safe, and there are several ways to get screened for colorectal cancer, even at home. You have options. Next slide, please. So I'm just going to show you a little bit about what the creative looks like as of now. And we think this is so important. Right now, we've been driven by fear and all these other things with COVID and confusion around the election and just a whole host of things, unemployment, et cetera, this year. And, we want to feel like we are in control, or you are in control. And so next slide, you'll see the actual creative that we came up with. So you can see here, the world has changed. So don't let COVID-19 stop you from getting screened. Your healthcare provider is waiting to talk to you today about your screening options. And then you can see here, it's a little bit of some interesting, the world has changed visuals, both this upside down bike, upside down basketball court, and then you have the one that's directed at primary care physicians on the right. The world has changed, but your risk for colon cancer has not. Next slide. So what this does is, if you click on this ad or this pop-up or whatever you want to call it, it takes you to this site, and you click start here to find your screening options. Next slide. And basically what it walks you through, as of right now, it doesn't have every one of these steps, but when we go to iteration 2 in those tier 2 cities and tier 3 cities in January, February, it will get you to the site, as I just showed you. You'll click on this, you'll answer a really great adaptive questionnaire. You'll see on our next page who the advisors have been to make that happen. It's actually a risk stratification tool to kind of assess the patient's risk, both from low to high. It will potentially recommend a host of options for you based on that risk assessment tool, and will provide you links to education and a shared decision-making tool for those options itself. It will then ask you, do you have a GI physician? Do you have a primary care physician? And if you're pressing yes, on the back end of this tool, we will work with many different healthcare systems, et cetera, to connect their EHRs to the back end of this system to be able to connect you right to make a GI appointment with their scheduler, or connect to a national database of GI physicians and or primary care physicians to make sure that you get connected to get a test. So then we go to the integration piece. So let's say you decide to get a FIT test or a Cologuard or another type of screening test, and you test positive. It will follow you through that process. So the company that we use on the back end will send text message reminders, send phone calls all along the way, both to get the screening, number one, and then number two, if there is a positive test, to make sure you 100% get that follow-up colonoscopy. So that's kind of this full circle, high level workflow navigation. Next slide, please. You can see here, this is our advisory group. A lot of folks that you know here, Chike DeBenny, Gerardo Brooks, obviously Rich Wender, et cetera. I won't read all these names. We've got a great group, both on the medical side, but also on the technological side as well. Next slide. So measuring success, you know, on the awareness side, we're actually looking for overall impressions, the estimated ad recall, and the pull-through rate. But really, bottom line is how many people are clicking on those ads and getting to this website. And then on the nav tool side, it is how many people are actually getting through the questionnaire and completing that form to make sure that they get that recommendation for screening. And obviously, we're also capturing their emails, et cetera. And we do have this connected. The Alliance has a very robust call center or navigation center for our patient services, treatment services, so they can have the option of calling one of our navigators if they have questions. Next slide. So here you can see the timeline. Q3, we've already launched. Q4, we're in our phase 2 of road mapping for our nav tool. We've launched once again the creative. And then in January, Q1, February, March, April, and so on, we will turn back on our awareness campaign and launch the phase 2 patient navigation tool. Next slide. So if you need any more information about this and have any questions, obviously, as Laura said, enter it into sly.do. But Trudy Loper, our Senior Director of Screening at the Alliance, can also answer many questions. So thank you, Laura, and thank you to NCCRT for getting us the opportunity to share.
Great. Thanks so much, Michael. That sounds like a great program. I look forward to discussing more after we hear from Dr. Greenwald. So I'll hand it over to you.
Thanks, Laura, and congratulations to Renee and Michael for the amazing work that you are doing personally and your groups are doing around the country. Really been a tough time the last 6 months. And you know, in a session talking about innovative strategies to reach patients for colorectal cancer screening during COVID-19, you know, I thought I would take you a little bit about sort of what we've done in and around New York City, which was initially, you know, the epicenter in the United States, or one of the epicenters in the United States for COVID-19. And we really grappled with what to do initially, what to do in the short term. And now we have some experience from the last 6 months that I can share with you. So let's go to the next slide, please. So, you know, it all started with a tsunami. And this is sort of a graphic of New York City. And it really was a tsunami. It was like a wave that we didn't expect. We didn't know was coming. And we had to react really, really quickly. So what I'll do briefly is just take you back where we were and then show you where we're going once that tsunami hit. Okay, next slide. So the first thing that we had to do as gastroenterologists, much like other medical professionals, was think about what needed to be done immediately and what was essentially not urgent, but could be deferred for a period of time. So if I relate this to colorectal cancer screening, all three GI societies and the GI societies together, along with lots of other groups around the nation, put together roadmaps and algorithms and timelines and playbooks and all sorts of things, recommendations basically for how to proceed. The immediate need we had was to decide what endoscopic procedures needed to be done urgently and which ones were not urgent. And as you can see, if you look to the right on this chart that I presented, screening or surveillance colonoscopy, following up colonoscopy for a positive FIT test, in everybody's mind came in the non-time sensitive, meaning didn't need to be done tomorrow, but certainly something that we started to think about, okay, as the world opens back up again, as we control COVID better, how would we strategize that and how would we bring people back? From the endoscopy point of view, there were obviously other procedures that were urgent or emergent, and we continued to do those. We continued to do those all the way through in New York City and around the country. So what's up here is the AGA Institute's rapid recommendations, but if you go to the next slide, in New York, the GI Society in New York, the New York Society for Gastrointestinal Endoscopy, put out its own list along with the ACG of elective procedures that might be delayed. And if you look right at the very top of it, it was screening and surveillance colonoscopy in asymptomatic patients. And there were a number of others as well. Okay, so then we move, that was March and early April. Now, if we go a little bit further into April, next slide. I found it interesting to go back through some presentations that we made in April about what was likely to happen over the ensuing few months, and now looking back in retrospect, what actually did happen. So interestingly, on April 20th, in an ACG webinar, we talked about plan for limiting reopening of ambulatory surgery centers and offices once the number of new COVID cases begins to decline. We estimated in the New York City area and around the country that might be in mid-May to June, which is indeed actually what happened in most of the country, certainly happened in the New York City area. And the strategy for bringing people back was to bring in those that we had classified as semi-urgent, those were below the urgent cases, or patients rather. Then we would work on patients who had symptoms, let's say rectal bleeding, abdominal pain, weight loss, and all along we were concerned about those patients. And then we talked about patients who were FIT positive or multi-target DNA FIT positive, and below that were colorectal cancer screening patients for colonoscopy. We predicted that by the summer we would be doing elective procedures, and again in New York City and New York State, that's exactly what happened, and it happened around the country as well. And we predicted a couple of things that might happen that might facilitate bringing patients back safely and effectively. And it included COVID testing all patients and swab testing all doctors, nurses, and other staff. So in New York State, COVID testing of all patients pre-procedure has been the rule since mid-June. COVID testing of the staff is not the rule, although it is being done in certain facilities. Next slide. So were patients avoiding care? Well, you all know this, and the effects of this on both healthcare in general and cancer screening in particular, colorectal cancer screening, as well as skin cancer screening, mammography, cervical cancer screening, all suffered a sharp decline in March and April and recovered into June, and has largely recovered in the New York City area. So I can tell you that, our office visits are almost back to 100% again. Many patients are reluctant to come to the office, but many others want to come to the office. And our procedure volumes have actually almost recovered to 100% in most places. Everything is changing now as the prevalence rates have gone back up again around the country. Next slide. So one of the key things in bringing patients back is to reassure them that it's safe. And this is not an innovative strategy, but it's a very effective strategy. The innovation here has been in creating all sorts of information that's really patient-friendly, that really addresses the heart of the matter of is it okay for me to come back and have my colorectal cancer screening, for example. And I love Michael's comments a few minutes ago, about the world has changed, but your risk for colorectal cancer has not changed. We need to keep that message out there and make sure that patients understand that they need to continue doing the screenings that we've been recommending for years. So this is a picture of the Mount Sinai Safety Hub. I'm showing a video actually that says your safety is the new normal. Many of us in endoscopy and other outpatient surgical services participated in making this video, which was really designed to alleviate fear and show what was going on. And although it may have been obvious to those of us in the healthcare world, it wasn't so obvious to many patients and friends and family, actually. Next slide. So what was on that safety hub are information about what happens before your appointment, what happens when you arrive, including things like visitor policy and mandatory masking, symptom screening, what happens during your visit, hand hygiene, how we were doing social distancing, and what was happening behind the scenes. Patients were most interested in the bottom one, their separation of COVID-19 patients through screening and symptom checks, as well as continuous cleaning and what we were doing with the staff. Next slide. So the issues for prioritizing patients for colon cancer screening, colorectal cancer screening, and colonoscopy in New York City started with creating two premises. One is that colonoscopy remains safe, and I think it's a really important point that I'd love to talk about more in the discussion area. Colonoscopy remains as safe as it always has been, given certain precautions that we're now taking, and it's a good option for screening, not the only option, certainly a good option for screening. And one of the critical steps is identifying which patients should have higher priority for colonoscopic screening, and I alluded to that before. The issues are the ones that the patients were bringing up. Again, confidently reassuring patients that visiting a healthcare facility, or specifically an endoscopy facility, was safe, and that the colonoscopy was a safe procedure even during COVID. Certain priority colonoscopies need to be highlighted. So abnormal stool-based cancer screens, more on that in a moment. Anybody with a family history or a personal history of adenomas or colorectal cancer screening needs to continue to have colorectal cancer screening via colonoscopy. Inflammatory bowel disease carries its own risks, and high-risk genetic syndromes need to be screened by colonoscopy. Strengthening partnerships between primary care and GI in the New York City area has been a big deal in terms of making these issues clear. But it's also tempered by, sort of what's going on locally. Can we handle this? Were we sort of open for business? What kind of barriers were patients facing when they came in for colorectal cancer screening? And finally, all of the information that you've seen both in the initial session this afternoon and the two presentations that preceded mine about communication to disseminate better messages that promote options. So next slide. One thing that I think is really important as we talk about alternative ways to screen or for colorectal cancer screening besides colonoscopy, including the use of FIT and multi-target stool DNA FIT, are that they need to be followed up with a colonoscopy. So this message is critically important. I've seen data now that suggests that up to 20 to 40% of positive FIT tests don't make it to essentially the second step in that screening continuum, which is colonoscopy. We have to keep hammering that message home, particularly when we're talking about strategies to reach patients during COVID-19. And the last slide is really how to apply the NCCRT playbook to New York City. And this is information that was just shared at the recent C5. So that's the Citywide Colorectal Cancer Control Coalition in New York. We had a summit meeting earlier this month. Steve Itzkowitz, who's one of my colleagues at Mount Sinai, summarized the important points about applying that playbook to New York City, including the C5 Coalition and its partners and stakeholders continue to promote the importance of colorectal cancer screening. Again, all about communication between primary care referrers and GI specialists, designing, developing, and implementing systems for tracking these stool-based screening tests with necessary navigation and callback measures to make sure that we don't lose people along the way. Again, working closely with New York State and City Department of Health, this applies anywhere around the country, to monitor COVID infection rates, because we can look at different strategies for colorectal cancer screening depending on the community infection rates, whether they be low, in which case we would continue to perform screening colonoscopies as usual and reassure patients about safety, versus high, where we prioritize colonoscopies among higher risk patients and utilize stool-based testing for the others. Next slide. And I really like ending with this. picture showing again that, lots of people are superheroes in this fight against COVID. So thank you very much for your attention.
Thanks so much, Dr. Greenwald, and I really love that picture there that you close with. So true that so many people are true heroes and are continuing to face the pandemic every day, and working through these issues of how to help patients appropriately and safely re-engage and continue screening is so important. So let's dive into our questions so we can have some discussion time now. So we're gonna go kind of back to the beginning, just based on the way the questions came in. So I think the first question is for you, Renay. The question is about the FitKit video. And the question is the video available for use by other organizations?
Yes, it is. We just ask that the content not be altered, but it is available to everyone.
Great, that's such a great resource. And then another question that I think is actually for both, maybe you, Renay, and also you, Michael, about somebody asked, can we use or adapt the social media messages and ads for other organizations?
Yeah, Laura, I can take the question. I mean, I would love for anybody that is interested to email T Loper. It's TLOPER. We can put it in the chat at ccalliance.org. But yes, absolutely. We're looking for multiple partners and folks to help disseminate, specifically in March of 2021. How can we amplify the message specifically with the creative and the social tiles that we have? So yes.
That's great. Thanks so much. I'll also mention, I think I forgot to introduce myself, so apologies, everyone. I'm Laura Makaroff. I'm Senior Vice President for Prevention and Early Detection at the American Cancer Society. But let me just mention quickly on the ACS side, American Cancer Society side, we're actually working on, similarly, a public messaging campaign about returning to all cancer screenings. So it's not colorectal specific, but we are actively working on that, and we're hoping to have similar messages that are available for co-branding in early Q1 of 2021. So those are being tested right now. We're working through that for kind of all cancers. So the colorectal piece will be in there, but it'll be a nice add-on, and we can partner together with any of you and all of you to really help people return to all cancer screening, including colorectal cancer screening as safely and quickly as possible.
Yeah, so can I say my role as
Yeah.
public awareness and social media chairperson or co-chairperson, that the use of social media for that message is absolutely vital, because it's so wide-reaching and so easy to do. So I'm glad to, that we're all sharing all of these messages. It's really important.
Yeah, super important. Great. Another question kind of around the messaging and awareness education campaigns about how many different languages are your materials and videos available in? And that's for Renay.
We have it in Spanish and English for all of our education materials. And because we just implemented the FIT virtual video in June, and we've had such great success rate, we are in the process of developing a Spanish language as well. Oh,
great. That's really great to hear. Such a nice way of reaching different parts of our population. So great. And then there was another question. I think this also came in during your presentation, Renay, about how do you define medically underserved and the target population?
In our program, we always receive referrals from a patient's medical home, whether that's a free medical clinic or a federally qualified healthcare center. So they determine the financial eligibility for our participants, and we are looking at 200% of the federal poverty line and below. And individuals are either uninsured or have insurance that screening is not covered, and it's a high deductible health plan. And so we'll cover those as well. That is not as common, but we do have, 98% of our patients are all uninsured, and we do work with the homeless populations as well.
Great. I wondered, Dave or Michael, do you have other thoughts on that? The question around how you're looking, specifically, I was wondering, Dave, in the clinical setting, are there ways that you're using your EHR or other registry functions to sort of find your patients who may be more at risk for disparities or are medically underserved in some way? Can you speak to any ways that you're thinking about that and trying to get to the hard to reach, we'll say?
Yeah, sure. I mean, there are lots of ways that, the first important point there is that COVID-19 has, disproportionately affected the medically underserved populations, whatever race and ethnicity they are all been overly affected by COVID. And so we all have to recognize that. And then the impact, that's just COVID. Then if we talk about the impact on things like colorectal cancer screening, that's going to be magnified over the years. So we do reach out to various communities around the hospitals, catchment area and around New York City, essentially by looking at colorectal cancer screening rates. And then through the Department of Health and a group that I work with at C5, really target messages to specific communities that we know are underrepresented in screening right now. And they often involve targeted messages in specific languages, or looking at particular communities and what might affect those communities in terms of reaching out to those people. And NCCRT has done a marvelous job at creating some of those messages. So yeah, we are absolutely looking at that. And we're very worried about that population. It's a real enormous problem.
Yeah, agreed. I think we're all worried about it, and really worried about the disproportionate burden of COVID on top of the already disproportionate burden of colorectal cancer. Michael, do you have anything to add on that topic that you all are working on or thinking on as far as reaching medically underserved populations?
Yeah, no, I mean, I think it's just the piece around like the holistic approach, right? Kind of how David said it. It's like, yes, you can have social media campaigns, you can have conversations with your primary care physicians, et cetera, but are you going to your primary care physician? So where do we meet folks where they are? And I think that's one of the things, where, people like Charles Rogers and others throughout the country are really doing a great job. So whether, talking about churches, you're talking about barbershops, you're talking about other places where these individuals are and how do we meet those folks where they are and get those messages out on the ground? And I think it's even harder right now because of COVID-19. You can't necessarily, for example, we're doing something in Philadelphia with WURD radio, all African-American radio station. And we were going to have a bunch of in-person events where you handed out fit tests. Well, obviously we can't do that anymore. So how do you kind of recreate that on the ground grassroots piece? And I think that's the challenge. But yeah, it's more, Laura, I think a kind of like this holistic approach.
Yeah, great point. Can you speak, Michael, to the results from your 2-week test in the first few cities with your awareness campaign, and what did you learn? And the person who asked the question was just giving you, congrats on all of the great content that you all were able to put together.
Yeah, absolutely. So in the 3 cities we looked at, which was Philadelphia, DC, and Houston, we had about 20 million impressions and about 5 million people reached. We had 20,000 people come to the navigation site. And of that, I think it was 10 to 12% of people that filled out the form. So what we've done since then is obviously a lot of tweaks, both tweaks in the language and the creative, so on social and on programmatic. And then we continue to tweak both the questionnaire, the number of questions, how people are going through the questionnaire, and what is the link between the actual ads people are seeing and the homepage. So the biggest thing we learned from direct to consumer marketing, let's say it's like Chase Bank and Chase wants you to get, open a bank account. If you see an ad that says, open a bank account, and then the homepage looks totally different and is widely different, they're going to leave the page immediately. You're going to have a really high bounce rate. So we've been in the process of really diving deep into that and trying to improve those conversions as quickly as possible.
Cool. That's great. Thank you. Also, for your campaign, Michael, what made you decide to go beyond the awareness campaign and include your own version of patient navigation? The rest of the question says the integration confirmation steps seem very ambitious and hard to build. Do you target integration with a limited number of partners?
Yeah, it's definitely hard to build. And we are starting, as I said, in these first 5 cities and then potentially 15 cities. We're also working with AmSurge, Physicians Endoscopy, and others to kind of test this back-end EHR piece. And then we're actually also very lucky because we've had some high-level partnerships with the Blues and looking at their back end of their each EHR, specifically Independence Blue Cross Blue Shield and others. So absolutely, it is difficult. And I think we're gonna learn a lot as we continue through this process. And I'm sure we're working with David and others in the societies to make sure that this is successful and integrated. And I think there's that GI, which is the right GI finder, right? And which is the right, primary care physician finder. And what if you're not in there? And there's all those different questions. But bottom line, we picked to do the navigation because it's the number one reason why people don't get screened. And, it's such an important piece. And I think we can make a huge difference in saving lives over the next five years with that navigation.
Yeah, navigation in all forms is critical to this whole thing. I mean, I can't speak enough about the value of navigation. If I go back to your other point about the medically underserved communities, I mean, the value of navigation in those communities almost outstrips anything else we can do. The most important thing for colorectal cancer screening is to have a trusted health professional recommend, screening to. But after that, the follow-up on it is so much dependent on having a navigation that's culturally the same, that you understand, that speaks your language, that understands your issues. It makes all the difference in the world to have a buddy to complete colorectal cancer screening, whether it be done by FIT testing or FIT DNA or colonoscopy. And then to go to the second point, Michael, we've started this is a Sinai thing, but we've started a pretty aggressive digital navigation program. So this replaces some of the burden on people and allows those that are technically competent to get reminders all about various forms of navigation around colorectal cancer screening. So we're using it as a way to remind people 10, 5, 3 days out that their procedure or their testing is coming up, and then how to navigate through the specific day of the procedure and what to expect afterwards. That is valuable all by itself, and it also then frees up our human navigators. We haven't exactly decided what to call them, but you know what I mean, to then work with the population that isn't as digitally savvy or won't respond to that kind of navigation. And I think that two-prong approach may be better than either prong alone.
I like that. Yeah.
Yeah, so important. Navigation, plays such a critical role, and really is so key. And maybe more so now. I don't know, but it seems to me that as people are more isolated and maybe having even less frequent interaction with their usual healthcare systems and medical homes, that role is so critically important.
So, if you talk about strategies to bring people back, one of our main challenges in New York State, the state mandated that anybody having a medical procedure, surgery or endoscopy, colonoscopy counted, needed to have COVID testing before the procedure. So that presented a navigation challenge like we've never faced before, because there are all kinds of logistics that had to be done initially, 2 days, then 3 days, now 5 days before the procedure. But just getting that done and getting the results back and getting the right test done. You talk about a barrier to colorectal cancer screening. I mean, this is the biggest barrier we've faced. And it all turns out to be a giant navigation project. And we've had to expend a tremendous amount of resources, mostly human resources, our teams, walking patients through this and dealing with their problems. It's really, really critical.
Yeah, super critical. Renay, did you have anything to add on this?
Yes, as I mentioned earlier about our patient navigation being, completely available to the patient, our navigators are available 24/7 in our program because of colon preps on weekends and evenings and different situations. And when we talk about that little decrease that we've had in our FIT compliance, we do feel it's because of that one-on-one connection that we've kind of skipped over. But I'll tell you, we have in our program, we have patient navigators that call us back in 3, 5, 7 years that have reached back out to their same navigator and said, hey, it's time for my screening. What do I need to do? And so, when you're dealing with a medically underserved population, for people to remember, keep a phone number there and to have that great of an experience, that's what we need, because that makes them engaged in the process and more communicating within the public and their own family. And that's what we want, is we want the word to spread. We want good experiences to promote more experiences.
They created a buddy. It's perfect.
Yeah, that's great. That's so great. Speaking of the navigators, the question maybe for everybody who's using navigators or has experience, do your navigators have cultural competency training, and are they prepared to assist patients with barriers and access issues?
Yeah. Go ahead, Renay.
Yes, our navigators do have cultural competency training, as well as sensitivity, especially in our state. We have patients with no running water, no toilet facilities. We have lots and lots of transportation barriers, I think, are real across the country. We're a rural state, so we do have a lot of barriers that we work with, and we try to overcome those barriers. We get very creative with our patient navigators. And it is a tough road. You can't always presume what we have every day available to us is accessible for the next person. Simply, running water to mix a prep and to do other things. And so that is extremely important. And what we do for activities, we also look at religious barriers. We have certain situations where people may be of a faith where they can't have gelatin products. They can't have certain other things. So we need, and also when someone comes up to meet with one of our staff, if they come with their hands behind their back, they may be of a faith where they cannot touch a person of the opposite sex. So we have to be very, very sensitive to that in our program. And I think we do a fantastic job with our staff, and they do an amazing job as well.
That's great. Great. Any other thoughts on kind of any specific navigation activities that you've been working on or seen as successful, or ways to help with the cultural competency of all of our staff and navigators?
Multilingual is very important, obviously. I mean, that's no surprise there, but people relate to people they can talk to. Think how scary it must be to go through colorectal cancer screening in another language, right? So, we at least, within our programs, we've tried to understand the communities that we actually are likely to be serving, and have made sure that we have navigators that are fluent in those languages.
Yeah, so important, the trusted messenger, and really being able to have, people, from the community, serving the community, and whatever that community looks like. And our 80% in every community, efforts really speak to that. And it's just so important. So, congrats on all of your work. Now, one important question on navigation. We all know that few people pay for navigation, right? A lot of systems, a lot of communities are reliant on grant funding to really help bridge how navigation is available. So can you guys speak to any thoughts or ideas around this issue of really continuing to push for funding for navigation services overall, and the importance of that?
Yeah, I mean, I can touch on that from an advocacy perspective, and then I'm sure, David and Renee can touch on it from different perspectives. So for us, we've been working really hard to raise funds and use kind of unrestricted dollars that the Alliance raises from events, et cetera, to fund this. But I also think, if you think about this year and payers and how well they are doing, and they are doing really well, unfortunately, this year. I mean, and I say that unfortunately just because, right? We are really looking towards two payers, both the Blues, Aetna, and United Healthcare, et cetera, to help at least kickstart some of these efforts in millions and millions of dollars. Because you are absolutely right. There's these small grants, $200,000 or $100,000 or $50,000. And yeah, I mean, I think, Renee, you guys have done an amazing job in making it sustainable. But if we're going to do this on a national level, we need hundreds of millions of dollars. So, one of the things that we are looking at is, can payers really play a big part in helping to make this sustainable?
That's a great idea. And the policy levers are so important. And the policy from the health plan level makes a lot of sense.
Yeah. The policy stuff, I agree, is critically important. From a health system point of view, we were able to make a very, I think, cogent case looking at population screening rates. So let's say the country's screening rate is at 65, 67%. And, our goal, let's say, is 80%. But, so that gap, that 13% that we haven't found, and in many cities and areas, it's certainly a bigger gap than that. If you go to federally qualified health centers, I mean, the rates right now are 30%. So there's an enormous gap there. But you can make a very strong financial case for the incremental cases or the extra cases that you will get, procedures that you will get from colonoscopy, more than offsetting the cost of many navigators. It's a very easy case to make. And that's actually how we started our program, went to the hospital and said, this is a win-win for everybody. We are going to reach a population that needs colorectal cancer screening. We've shown it before in breast cancer screening, but it will apply equally well here. And the downstream effect of it will be positive financially. So everybody wins.
Yeah, that's great. I'll make one plug for a resource that's on the NCCRT website if you haven't seen it, just for our attendees. There is a how to pay for screening navigation toolkit resource. It's a couple years old, but still very relevant, and has some really nice case studies and examples of ways to structure navigation programs and kind of innovative ways to think about payments. So just make sure everyone knows that that's on the NCCRT website. Dave, you mentioned in your remarks, I guess, getting back to this issue of people who are higher risk having access to colonoscopy.
Yeah.
Is there anything you wanted to say on that as we start to wrap up?
Well, it's a concern, right? It's a big concern.
Mm-hmm.
So, we worry about patients who have a family history, for example, maybe a first-degree relative who, now are even more scared to come in for colorectal cancer screening because they're going to get COVID. I see this every day. I mean, we have patients and they're like, I really want to do that, but I don't know if this is the right time. And, our job has really been to convince people that their risk continues on. It's exactly what Michael said. Their risk continues on as time marches on. And we have to reach those people. So in terms of your question, identifying the high risk folks, and then, maybe redoubling our efforts and saying, you can't wait. This is really important.
Mm-hmm.
That's the approach we've taken.
Yeah, really, really important. And I think interestingly, some of the higher risk patients may have immune compromise at some level. So adding like this layer of like additional fear, but really helping people understand the safety measures that are in place, like that the risk is continuing, that will keep you safe and work through the necessary care that you need. I think that's so important. I think we can try the video again. Let's try the video again.
That'd be great.
And see if the sound works. Yay! And
has
then
a poop emoji in it and everything.
Yeah, we'll come back as a group and do some closing comments, and we'll wrap up right at 4:15.
Fantastic.
What do we have here?
Oh, that's my FIT kit. It's time for my colorectal cancer screening.
That little kit can screen for colorectal cancer?
Yes, it's one way to screen for colorectal cancer. Colorectal cancer begins in the colon or rectum from a small growth called a polyp. A polyp is a growth of tissue that is formed from a group of cells. Not all polyps will grow into cancer. Cancer happens when the cells in the polyp grow out of control. The FIT kit just looks for hidden blood in your stool, which can be an early sign of an aggressive polyp or colorectal cancer. Since I have no family or personal history of colorectal cancer or polyps, I'm able to use the FIT kit.
I like the idea of completing the test at home, but I don't want to touch Dookie.
I'll just relax. I pee before I go number 2 and flush to make sure I have fresh water. Then just lay the paper insert provided in the kit on top of the toilet water. Then I just sit on the toilet and go. To collect my sample, I open the sample container and gently scrape the outside of the stool to make sure the sample covers the ridges of the stick completely.
Look, a pooper scooper.
Okay. Then I insert the stick back into the container and twist the lid firmly. The paper and stool is flushed down the toilet. After that, you just place the bag in the envelope provided and mail. Piece of cake.
I'll pass on that cake, but I think I can handle this.
If the test is positive, it means blood is present in my stool. My doctor said I would need a colonoscopy to look for the source of blood, which could be from a polyp, cancer, or other reason.
Wow, this is really important.
It is. But if the test comes back negative, like last time, and I've had no changes in personal or family history, I'm able to do this test again next year.
Well, I don't want to be a party pooper. I'll talk to my doctor about my colorectal cancer screening too.
That was great. I'm so glad we tried that again. Congrats, Renee. I love that. It seems so quick and simple, but super important and digestible information. That was not on purpose.
I love that.
That is funny. Yeah.
I love that. That is amazing.
Yeah.
We got to get that out to the world. That's like a game changer.
Definitely. Oh, you're on mute, Renee.
You're on mute.
Yeah.
You'll have to check out our Clear Liquid Diet video. Our navigators worked on that project during the COVID shutdown, and it is really cute.
All right. I'll do it right after we're done.
Yeah, that's great. That's so great. Well, that's a really nice way to end. With just a minute left, does anybody have any closing comments or thoughts to leave with the group?
I have a quick one. This is really important. Getting people back to screening is really, really important. And I don't think this audience underestimates the challenges, but a lot of people do. And we have to keep getting the word out about how difficult this is. And it's not going to get any easier in the next few months. So we got to keep at it.
Yeah. Agreed.
Agreed. Very, very, very timely and important, and agreed. Like, we are just the group, and all of everybody watching today and will be with us tomorrow. Just the group to keep the drumbeat going and help people recognize that this is not something that's going away. And then honestly, the risk of delayed screening is going to continue to exponentially rise as we continue to endure the pandemic. So stay safe, wear your masks, keep your distance, and make sure your patients and family and friends know to get their screening done on time and when it's safe. Yes, thank you.
I respect you.
Very nice, yes. Just as we close, a reminder, thank you so much to our panelists for your great presentations. Be sure to check out the exhibitor booth. You'll click from the CVent platform, you click on visit exhibitors, and there are people waiting to talk with you there. And then take advantage of all the other networking opportunities that are part of your agenda as well. So we will see you later and enjoy the rest of this virtual conference. Thanks again for joining us.